I am Kristen. I help Harry run the MIDAS Coordination Center, and he is currently on vacation right now. For today's seminar, we have Mallory Harris, and she is a PhD candidate in the Stanford Department of Biology, where she is an ARC scholar. She will be discussing today's social division and vaccine information. Mallory, feel free. You can go ahead and get started. Thank you.
All right. Thank you so much for that introduction. As you said, my name is Mallory. I'm a grad student in the Stanford Department of Biology. And I'll just start out by saying that I'm planning to defend my dissertation in spring of 2024. So I am starting to look out for postdoc opportunities, and feel free to reach out to me if you'd like to talk more about that or send me anything that looks interesting. A little bit of background on me is that I entered graduate school knowing that diseases would emerge and reemerge in coming decades, exacerbated by climate change and other anthropogenic change. I wanted to help develop tools to predict pandemics and understand drivers of disease burden with a focus on mosquito-borne illness. And I assumed that as a scientist, if I could pinpoint when and why an outbreak might occur, policymakers and the public would respond to disease threats by taking necessary protective actions. And this was in the fall of 2019. So very quickly, I started to see those assumptions break down as COVID started to spread in the US, and it really changed how I viewed my research. At the same time, as people began talking about flattening the curve, my lab mates and I developed a model with an eye toward understanding the measures we might take after the initial few weeks of shelter in place. And this was an early, pretty simple model. And we, about a year and a half, went back and looked at our model's near-term forecasting ability in those first few months. And we found that at first the model performance improved as we had better testing and more data to fit the model, as one might expect. But then around June, our model started to really deviate from reality. And one of our explanations for why this may have happened is that we had this really simple behavioral assumption that people would keep their contacts at the same low level through shelter in place. Now, this worked in the first few weeks, but then it started not being able to account for what was actually happening, which was this gradual relaxation of protective measures and a much more complicated behavioral response as individuals became increasingly responsible for deciding which protective measures to adopt. So my collaborators updated that model and built in some mobility data. And in the meantime, I started to think more about this question of how to incorporate human decision-making and behavior into disease models. Based on this realization that when we're talking about modeling human infectious diseases, we need to understand both the pathogen and its host. And it seemed that we had a pretty decent understanding of the pathogen's biology pretty early on. But what we were really missing in these early models that I was working on were the being able to adequately capture the types of human decision-making and behavior that we saw unfolding around us. So I became interested in working to better understand how human activity works and how we can incorporate it into our models. Today, I'm going to be presenting on the first two chapters of my dissertation, which will show some of how I'm starting to approach those questions. The first has been published in Evolutionary Human Sciences, and it's an example of how we can incorporate socio-behavioral processes, particularly social division and adoption of protective behavior based on perceived risk into disease models. And then the second is a preprint under review that's up on medRxiv, where we tested a hypothesis about how health misinformation spreads, specifically that people who appear to be experts are important sources of anti-vaccine misinformation. Then I'll close with a few thoughts on some of my potential next steps, and I'm hoping that we can then have a bit of time for questions and comments, and I'd really love to hear how other folks on this call are approaching this aspect of behavior. So starting out with that first project, I started looking at these awareness-based models. So this is a type of model that includes both disease dynamics and the uptake of protective behavior, based on this assumption that as a pathogen starts to spread in a population, you'll get some observable severe impact like deaths or hospitalizations, which in turn will shape people's awareness. They will see the counts of deaths that have occurred recently and evaluate their personal risk of the disease, and then decide whether to adopt protective behaviors, things like wearing a mask or getting vaccinated, which can in turn reduce future infections. And so we're setting up a feedback loop, and as with any feedback loop, you can get some funky dynamics. So other folks have shown how these types of models can produce plateaus, oscillations, and shoulders. And while there's been some work looking at how awareness-based models work in the context of heterogeneous social networks, these models generally overlook the effects of strong social divisions. And we don't need to look far for examples of why those might be important in real life. For example, COVID has had really different impacts depending on factors like race, ethnicity, socioeconomic status, urban-rural divides, and political affiliation. And those have been mirrored by differences in attitudes toward the disease and also willingness to adopt protective measures. So I'm going to formalize this concept that I'm talking about and call it awareness separation. And it exists along this spectrum where I'm showing you two of the more extreme ends. So you can either have uniform awareness on one extreme or separated awareness on the other. Let's say you had a population split into two groups, green and pink. If you have uniform awareness, the green group is paying equal attention to disease burden in their own group, in the green group, and in the pink group. And this also means that both of the groups will end up having the same perception of what's going on and what the risk of the disease is. But if you have separated awareness, the green group is paying more attention to disease burden within the green group, and the pink is focused more on the pink group. Now, if the two groups are also experiencing different disease burdens, then you'll start to see differences in behavior that might feed back into changing epidemic dynamics. So I'm going to use this, look at how awareness separation can affect epidemic dynamics and the relative disease burden of different groups here. And more specifically, I have these three questions where I'm looking at how awareness separation interacts with other socio-behavioral and biological factors to change disease dynamics. So in the first part, we'll look at awareness separation and mixing or contact rates and see how they can interact to widen or close disparities between groups. From there, I'll look at the more long-term epidemic dynamics in a split population and see how fatigue, which is a gradual abandonment of protective measures over time, can change those longer patterns. And then finally, I'll look at vaccine efficacy and immune strength and how awareness-based vaccine uptake can change disease burden. To answer these questions, I'm going to run simulations for two different compartmental models. The first focuses on non-pharmaceutical interventions or behaviors that reduce the likelihood you get infected or infect others. These are things like wearing a mask or social distancing. I'm starting out with a basic SIR compartmental model, susceptible, infected, recovered, where some infected people die from the disease. And we track whether behavior is unprotective or protective, which is the second letter in the compartment name. And then again, as a reminder, the protective behavior will both reduce your likelihood of getting infected and passing the infection on to others. We also allow people to switch their behavior, so they can become protective through awareness of recent deaths, and that's going to be proportional to recent deaths. And then you can lose protective behavior with fatigue, which is just a constant per capita rate. Finally, we'll also layer in an additional type of social division, which is mixing. So again, this is related to contact, or this is about contact rates. If you have uniform mixing, then the pink group is equally likely to contact pink or green. So they're acting as sort of one population where everyone is intermingling. If you have separated mixing, green is more likely to contact green, pink is more likely to contact pink. So we start out by splitting the population into these two groups. They have the same size, and the only difference between them is that the pathogen is introduced in the pink group and then spreads into the green group. So this is how we start out with the difference between the groups. We're going to look at infections over time in different combinations of uniform or separated awareness and mixing. So first, what we're seeing here is that if we just have uniform mixing, it doesn't actually matter whether awareness is separated. The epidemic plays out the same in both groups, and that's because the pathogen is able to spread really quickly from the pink group to the green group. However, when we have separated mixing, awareness separation becomes important. If you have uniform awareness, it increases differences between the groups. So the pink group, where the pathogen was introduced, has a larger epidemic, and the green group has a smaller epidemic. This is because there's some delay in the pathogens spreading in the green group. And so during that time, the green group can see the epidemic starting in the pink group and build its protective behavior early on, which allows them to reduce the total size of the epidemic. But if you have separated awareness, the green group is focusing on itself, and so they actually lose that early warning, and you end up with the same peak and total infections in both groups, just some time delay in the green group due to those initial conditions. So going forward, I'm going to focus on the case of separated mixing, because that's when we really start to see these stronger differences between the two groups. And now we're going to look at a longer term time frame, which is where fatigue, that relaxation of protective measures over time, becomes important. So as a reminder, when we had separated awareness, the initial peaks were about the same in both groups. And we can extend things out for longer and see that as protective behavior starts to wane, you get these second and third peaks that are also about the same size in both groups. But with uniform awareness, you had that difference in the size of the first wave. Specifically, the green group adopted protective behavior early on, but that means that they're left with this large susceptible population because they had a small first wave. And so the green group ends up with these large later waves that actually exceed the first wave in size. And I think that this figure is really interesting because qualitatively it resembles some of the dynamics that we saw early on in the COVID pandemic across different states in the US. So when I look at the pink line, I see places like New York and Washington that had really large first waves and then low level transmission for the next year or so. Whereas the green looks to me like Florida or my home state of Georgia that had smaller first waves, but then larger second and third waves going into the summer and winter. Now, these phenomena that we saw were likely a combination of a bunch of different factors, right? There was also probably climate, definitely policy contributors, and it's important to look at all of those. And I can't say anything causal based off of the fact that two lines look similar. But I think it is, this does show the importance of building in these types of behavioral processes because they are able to alone reproduce the types of complicated dynamics that we've seen play out in real life and are trying to explain. So this is part of my pitch for why behavior can be important. Next, I want to shift to a slightly different model where people can avoid infection by becoming vaccinated. And vaccination is, again, an awareness-based process in response to mortality. So here, the second letter of the compartmental name is now, or the compartment name is now your immune status. So you start out unprotective. And then after infection or vaccination, you go to the recovered compartment and can't get infected for a time period. But then immunity starts to wane and you can become infected, but at a reduced rate, in addition to having some protection against mortality. So T is transmission and mortality, reducing immunity. And then after that, immunity wanes further, so you're unprotected against transmission, but you still have a reduced risk of mortality. That's what the M is saying. At any point, you can boost your immunity again by becoming vaccinated, and that's also awareness-based. So let's look at what vaccine efficacy and immune protection, coupled with awareness separation, mean for epidemic outcomes. In this scenario, the pink group is again starting out at a disadvantage, but this time it has a mortality rate 5 times that of the green group. And I'm going to just start out with uniform awareness, and then I'll build in separated awareness. So the y-axis here is total deaths in either group, and then immune protection against transmission and mortality is increasing from left to right. So the immunity that you're getting both from vaccination and from infection. So all this first figure is showing is that deaths decline with stronger protection, and that the pink group that has a higher risk of death ends up dying at greater rates. That all makes sense. As mortality decline, so too does vaccine uptake, because the perceived risk of and actual risk of the disease decreases. And I should say there are actually 2 lines here, but since both groups have the same perception, they're getting vaccinated at the same rate, so it's totally overlapping. But then we get this potentially counterintuitive result, that even though the vaccine and immune protection have higher efficacy against infections, you still wind up with more infections at those highest levels of immune protection. And that's because fewer people are getting vaccinated. We can layer back in separated awareness, and then we see that the pink group, which is at higher risk, gets more vaccinated, which helps to close the disparity in deaths, although it does not completely eliminate it. On the other hand, a difference in infections can start to emerge as the less vaccinated green group ends up with more infections. So those are a few of the potentially complicated and counterintuitive results that you can get with these types of awareness-based models. And if you're interested in learning more about the model, playing around with our model, or potentially teaching other people about diseases and behavior, I worked with an undergraduate researcher, Kimberly Cardenas, to develop this R Shiny app, which is available online at that URL. And we'd love to hear feedback on it if you end up playing with it. So closing out this section, separated awareness can fundamentally alter epidemic outcomes, which makes it an important factor to consider in awareness-based models. It can widen or narrow disparities in infections or deaths, depending on the scenario. And the amount of awareness separation can have long-term consequences, determining whether you get second and third waves that exceed the initial wave's size. And finally, a more effective vaccine can indirectly lead to more infections because vaccine uptake can also decline. And now I'm going to shift gears to my second project. There's a huge assumption at the base of these awareness-based models, which is that everyone has access to accurate information about the epidemic at some scale, and that they respond proportionately. And we know that that isn't actually always the case. Specifically here, I want to turn to the question of vaccine decision-making during the COVID-19 pandemic. And that's because vaccine refusal poses a major and growing public health threat. According to recent estimates for the United States, 232,000 COVID deaths could have been prevented among unvaccinated adults had they been vaccinated in the 15 months following vaccine introduction. To give you a sense of scale, that's about equivalent to the entire population of Spokane, Washington. So this is a massive and devastating loss. By identifying actors who are particularly influential in vaccine decision-making, we can mount more effective health communication strategies and better counter escalating anti-vaccine misinformation. For a bit of potentially good news, experts, particularly medical professionals, remain trusted sources of vaccine information who are able to persuade people to get vaccinated. And there have been a bunch of studies on that, as well as looking at health information online that suggest that this effect also holds online and on social media. But what if we come at this from an opposite direction? Namely, are apparent experts who discourage vaccination also potentially important anti-vaccine influencers? Anecdotally, some of the highest profile sources of anti-vaccine misinformation over the past few decades have, after all, been people who claim to be experts. And this is something that a lot of other folks have already noted, and they've suggested that this is a specific and important category of anti-vaccine influencers. But the size and effect of this group of anti-vaccine perceived experts has actually not been quantified directly before. So that's what we set out to do using a large Twitter data set. And I'm going to use the term perceived experts in this study to emphasize that we're interested in people who present cues like professional and academic credentials that an audience could interpret as conferring expertise. However, expertise signals may be misrepresented or misunderstood. Here, we're going to take the perspective of the audience on a social media platform like Twitter, or the website formerly known as Twitter, where people often have limited information about their sources and have to rely on cues in user profiles. So this analysis is divided into two parts, where the first focuses on describing the community of perceived experts, and the second evaluates their influence relative to other individuals. Before we start answering those questions, though, I'm going to tell you a little bit more about how we constructed our data set. We used a collection of tweets involving keywords pertaining to COVID-19 vaccines, retrieved and stored in real time by the Center for an Informed Public at the University of Washington. We subset to April of 2021, I'll tell you why in a second, and we ended up with 4.2 million unique tweets and 5.5 million users who participated in the conversation either by publishing original content or retweeting, sharing someone else's post. Now, the reason we focused on April of 2021 is that is when all adults in the US became eligible for vaccination. So it was a really important time for vaccine decision making. A little bit more context, a refresher on what was happening at the time. First, we had this pause for a few days of administration of the Johnson & Johnson vaccine in response to reports of a rare but really serious clotting event potentially linked to the vaccine. So this gives us the opportunity to look at how different communities responded to reports of a rare but credible safety signal. And then also there were several salient rumors that were circulating at the time, specifically this idea of vaccine shedding, basically contagious COVID vaccine side effects. And this was not supported biologically, but it was a really prevalent rumor at the time. Using these tweets, we constructed what's called a co-engagement network. So this is analogous to the sorts of co-citation networks that you'll see in bibliometric analyses, where papers that often get cited together are linked. In this case, two users will be connected. They'll have an edge between them if they have been retweeted at least twice by at least 10 of the same users. So this is a measure of shared audience. This approach also has a nice filtering effect because you only appear in the co-engagement network if you're connected to at least one user. So we're focusing here on people who are getting some amount of repeated engagement within the vaccination conversation. And once we do this, we end up with just under 8,000 accounts in our co-engagement network. Here's what it looks like. So the circles are each an account, and the size of the circle corresponds to degree centrality. So that's the number of connections that you have to other accounts. In this context of co-engagement, it's basically a proxy for audience size, but it's not exactly that. The next thing that we did is we applied a community detection algorithm, specifically InfoMap, which is a hierarchical clustering algorithm, and that breaks our co-engagement network into two main communities, which contain roughly 80% of all the users across the co-engagement network. We took a sample of popular tweets from either communities, and I can tell you more about how we did this, but we determined the stances of those popular tweets, and based off of that, inferred that the largest community, which is in green on the right-hand side, was generally pro-vaccine, and the slightly smaller one was generally anti-vaccine. So pro-vaccine was arguing that vaccines are safe and effective, and anti was arguing the opposite.
And Mallory, we do have a question if you
yes.
to address that now.
Studies
Are you
out of
able to
Yale.
see the Q&A?
Yes. Okay, so here is a question about studies out of Yale and UMD demonstrated excess deaths among Republican populations following COVID vaccination. What are your thoughts on the association between political affiliation and vaccination status leading to excess deaths among unvaccinated populations? So it's a really good question. We didn't specifically look at political affiliation in this study, but I think this question is sort of, again, emphasizing that we really need to be thinking about these group level factors that are shaping decision making. I'll say that one explanation that I have seen of these results and these disparities are that maybe Republican voters are listening less to experts and they care less what scientists have to say. And I'll come back to that at the end if you remind me, but this study actually pushes back on that. So maybe foreshadowing my results, but we find that in this anti-vaccine community, which studies have shown are more likely to include conservative voters in the US, we actually do see evaluation of their own set of perceived experts. So we can come back to that. There's a follow-up study to this that does include some information about partisanship. So you can remind me at the end to come back to that. So going back to this first set of questions, here we're characterizing the group of perceived experts, particularly within the anti-vaccine community, by asking how many of them there are and what types of sources they share. Particularly, sharing of misinformation or academic sources can serve as a proxy for the types of arguments that they're making. So the first question here, again, is how many perceived experts are there and where are they showing up in the co-engagement network? And in order to answer this, myself and two research assistants, Shufan Wang and Ryan Mertfelt, went through all of those user profiles and classified users into different groups. Specifically, we had one category for non-English accounts. So if your profile was not in English, first, that made it difficult for us to assess whether you were signaling expertise, but also since our keywords were in English, it means that we might have some biases in our data set in terms of who you're interacting with and what you're talking about. So we're going to exclude those non-English accounts from these analyses, but I'll just add that as a caveat that this is a major limitation of this work. We also are going to exclude non-individual accounts, so things like media agencies, government offices. We really want to focus on comparing individuals to individuals. So within that individual English category, you are either a perceived expert or you're not a perceived expert. And here are some examples to really make clear how we define that. So when we were going through these profiles, what we would see is your name and your username, which are those top two features. And in yellow, I'm highlighting two examples of a name that has cues of expertise in it. So things like doctors, MD, right? These professional and academic prefixes and suffixes. Now, the profiles also will have a description. All of this information is user provided. And in blue, I'm highlighting an example of a Q of expertise in your biography. So if you have any Q of expertise in your profile, we will count you as a perceived expert. So here we have 3 perceived experts, and then only this person in the top right would not be a perceived expert. We can then go back to our co-engagement network. So here I'm showing our perceived experts in darker colors. Then in lighter colors, so for example, here and here we have some clusters. We have those users who are excluded from the analysis, either for having non-English profiles or for being non-individual accounts. And then finally, our medium colors, our midtones, are the accounts included in the analysis that are perceived non-experts. So of these included accounts, 13% are perceived experts. That's a pretty sizable proportion. And specifically, there are 185 of them, about 10% of the included accounts in the anti-vaccine community. So that's, again, a pretty sizable presence, even greater in the pro-vaccine community, where there are 17% of our included accounts. So now we know where our perceived experts are, who they are. The next question is what they're talking about. And to study this, we used a technique that's pretty common in this sort of misinformation studies, where we focused on tweets that shared links. So here is an example of a tweet with a link in it. And what we would specifically hone in on is the domain name. Here it's potionstudies.com. And we would compare it to a list of low quality sources. These are sources that repeatedly fail fact checks. And the custom is if an account is regularly sharing low quality sources, you can infer that they might be a source of misinformation. So our y-axis here is the proportion of users in a given category who shared at least one low quality link over the study period of April 2021. And we break it down by the anti versus pro-vaccine communities in the different colors. And then we also separate out perceived experts versus perceived non-experts. So this first finding is that pretty significantly, the anti-vaccine community is almost exclusively where these low quality sources are coming from. Furthermore, if we look within the anti-vaccine community, there isn't a significant difference in the likelihood of sharing a low quality link between perceived experts and perceived non-experts. So our perceived experts in the anti-vaccine community are sharing low quality sources, which is our proxy for misinformation sharing. The other type of source that we looked at is academic sources. And here we had a list of academic journals as well as preprint servers. So that's what we're looking at here. And the big difference that jumps out now is between perceived experts and perceived non-experts, where specifically perceived experts are more likely to share at least one academic link. Now, within that group of perceived experts, we do see greater academic link sharing by the pro-vaccine community's perceived experts. But even within the anti-vaccine community, the perceived experts are more likely to share academic sources. And this is kind of how you might expect an expert to behave, right? Sharing scientific articles and commenting on them. Now, I'll come back to this a little bit later, though, because what we didn't look at is what types of academic sources they're sharing. Now I want to turn to the second half of the project, where we actually are testing whether perceived experts might be a key group of anti-vaccine influencers. And specifically, we look at whether they show up in important network positions where they may be well posed to spread their opinions. And second, whether on average, we quantified how much of a boost in influence you actually receive from being a perceived expert. A bit more background on networks is that nodes that are more central within a social media network or really any information network play an important role in information flow. So here we want to ask whether perceived experts are overrepresented within the group of highly central users relative to their population size. As a reminder, the account size, the circle size here, corresponds to degree centrality. And we definitely see some large perceived experts in both communities, but let's try to actually quantify this effect and see if it's more than what we would expect just based on their population share. So here we have the anti-vaccine community on the left and the pro-vaccine community on the right. The y-axis is the proportion of perceived experts in the population. And we're starting out just looking at the full population of either community, which will be our basis of comparison. From there, we rank all of the included accounts based on their degree centrality, and then look at the proportion of perceived experts in the 500 users with the greatest degree centrality. So that's what I'm showing in this second bar, and we see that the population share of perceived experts is significantly greater within that group of central users only for the anti-vaccine community. And we can go even further and look at the 50 most central users in either community. So these are the super central users. And again, we find that perceived experts are overrepresented, especially, and in this case, there's a significant effect for both communities. So perceived experts are disproportionately showing up as people who are reaching large, important audiences. Finally, we want to ask if, in general, perceived experts are more influential than other individual users. How much of an influence boost do you get just from being a perceived expert? To test this out, to make this comparison, we used a method called propensity score matching. For each perceived expert, we selected a perceived non-expert who has similar profile statistics. So that's how many times they've posted, how many followers they have when they join the website. All of these things could affect your influence. This allows us to control for potential confounders and isolate how much being a perceived expert increases your influence. And then what we do is we compare the means of different influence metrics between the two groups. So as I said, we're going to look at a few different ways of quantifying influence, and that's going to be on our y-axis, but we're just starting out looking at median logged likes. Our x-axis is the difference in means between the perceived experts and the perceived non-experts. So specifically, if this is positive, then perceived experts have greater influence. So if we're to the right of this dashed line. Then I'm going to show a point estimate of that difference, a 95% confidence interval, and then I'll also circle it as I did here if there is a significant influence boost. So all I'm showing here is that there is a significant influence boost in terms of likes, where perceived experts within the anti-vaccine community get 37% more likes on their vaccine-related posts than do other individual perceived non-experts. And I'm just going to focus on the anti-vaccine community for a second. We can look at other ways of measuring influence based off of engagement. So we can also bring in retweets. And across all of these different metrics, we find that perceived experts are getting significantly more engagements, and that's our proxy for influence. Then we can also look at influence metrics based off of centrality. So we already talked about degree centrality. I threw in a couple of other centrality metrics. And while there is a tendency for perceived experts to score higher, we actually don't find a significant effect here. And feel free to ask me in the Q&A about reconciling this result with the previous section on centrality. Then the last thing that we can do is layer back in the anti-vaccine community, and we find for them as well that there is a significant influence boost for perceived experts. And further, we can compare the size of the influence boosts between the two communities. And across all of these different influence metrics, there is never a significant difference in the boost that you get from being a perceived expert between the anti and pro-vaccine communities, which I'll come back to that in just a second and explain why that's so interesting. So I'm going to wrap up this section now and give you some big takeaways. First, we were able to go beyond previous work that points to specific high-profile examples of anti-vaccine perceived experts and actually establish the scale of this group. Perceived experts were about 10% of individuals in the anti-vaccine community, which means that they constituted a sizable presence, and that this is actually a systemic problem extending beyond those more prominent examples. Further, if we compare, if we just focus on the pro and anti-vaccine communities, we find that 1/3 of our perceived experts are in the anti-vaccine community. Now, there's a big mismatch between this and the actual expert consensus, which is around 95% in favor of COVID vaccines. So there's some question then about whether what people are seeing on social media may actually contribute to this underestimation of the true scientific consensus in favor of COVID vaccines, which other folks have shown can actually then lead to reduced vaccine uptake. Second, we found that perceived experts in the anti-vaccine community are sharing both misinformation and scientific claims. Our finding that perceived experts share academic sources at higher rates suggests that they aren't just signaling that they're experts in their profile, they are actually performing scientific expertise within the anti-vaccine community, even while rejecting that scientific consensus. Now, as I kind of alluded to before, one thing that we didn't look at is which academic sources are they sharing and what are they saying about them? And that's actually potentially pretty important because other folks have looked at academic link sharing across the whole anti-vaccine community, not focused on perceived experts. And what they found is a tendency to share studies that are potentially methodologically flawed, studies from journals that are maybe of questionable quality, retracted studies, or misrepresent the conclusions of studies. So that's definitely worth looking into more. It seems like there's some things coming in. I'm going to actually, I'm going to come back to these questions after I close out. Okay. Yes, but good questions. So then in our second section, we were able to establish what folks have long suspected, that perceived experts are important figures in the anti-vaccine community. And we were actually to put some numbers on that and look at some potential, build the evidence for that, both in establishing that they are disproportionately central and also that they get significantly more engagements on average on their posts. And then finally, contradicting assumptions that the anti-vaccine community might simply care less about what experts have to say than the pro-vaccine community does. So this is what I was talking about before in response to that first question. We actually found that the influence boost for perceived experts in the anti-vaccine community is comparable to that in the pro-vaccine community. So the anti-vaccine community is engaging with people who at least appear to be experts, albeit potentially those who are within their own community and advancing a position in agreement with their own. Perceived experts are not only some of the most effective voices speaking out against anti-vaccine misinformation, they may be some of its most persuasive sources. And with that, I'm going to give the bigger picture from these two. First, we showed that behavioral feedback and group level heterogeneity can dramatically shift epidemic dynamics, which makes them critical to incorporate into disease models. We also showed how social media data can be leveraged to test a hypothesis about how vaccine-related information spreads, specifically that perceived experts are key anti-vaccine influencers. Moving forward, I envision developing workflows that link the type of socio-behavioral modeling in the first section with the type of empirical work I did in the second section. So for example, could we use social media data to quantify the extent of awareness separation in a real population? And again, I know that there are a lot of folks who are doing exactly this type of work, so I'd really love to hear what other people on the call have been doing in this space. Second, I'm interested in actually putting numbers on how human activity is impacting infectious diseases. This is going to be the focus of my third chapter, where I'm trying to attribute cases of vector-borne illness to climate change. And I also think it's important to understand how things like vaccine misinformation and health inequity are contributing to disease burden. Finally, I'm interested in applying my findings to develop interventions. One example of work I've already done is this collaboration with Joshua Weitz's group, developing an online dashboard that shows an estimated county level risk of COVID exposure at events of different size. And Ali Sinclair and collaborators then demonstrated how this type of dashboard can actually improve or make risk perceptions more accurate. Ultimately, I hope that by improving our understanding of how people react to outbreaks, we can build better models and develop more effective and equitable responses. So with that, I'd like to close out by thanking my funding sources, acknowledging my collaborators, especially my PI who has mentored me on all of these projects and just advised me so wonderfully, Erin Mordecai. I'd also like to thank Jevin West, who advised me on the vaccine misinformation project, and then give a shout out to all of the great research assistants who I've been working with, Kimi Cardenas, Ryan Mertfeld, and Shufan Wang. If you'd like to reach me, here's where you can find me. My email address, I'm Mallarone with a 0 on Blue Sky, Mastodon, and Twitter, although I am not really using Twitter lately due to the collapse of its content moderation around vaccine misinformation. And you can also read more about me and what I'm working on my personal website, which is this GitHub link. And then finally, if you're interested in reading more about these two specific projects, here are the citations, but I'm also happy to email them to you if you have a hard time finding them. And with that, I'm happy to take any questions, and it looks like there are a few coming in.
Yes, we do have questions here. If anyone else has a question, please feel free to type it into the Q&A.
Okay, so Brittany asked how we delineated pro versus anti-vaccine, which is a great question. Let me get to my supplemental slides too. So the first thing to know is we used a community detection algorithm. So what that does is, based off of sort of network structure, it breaks the network into different communities. And then what we did is we took a sample of popular tweets from those two large communities and manually reviewed those tweets. So I can give you kind of, this is my little activity where you can see what we did. So here are 4 tweets that weren't actually in our data set, but they were based off of the ones in the data set to give you a sense of the work we actually did. So maybe I'll give you a second. We had 3 categories: pro-vaccine, which is saying that vaccines are safe and effective; anti, which is the opposite; and then neutral, which is everything else. So you can maybe pick 1 or 2 of these, think about what you would label them as. And what we would have said is this first one is positive. They're saying that vaccines are effective, they're a way to protect yourself against severe COVID. The second, we would likely label as negative. It is implying that these deaths are linked to the COVID vaccine. This is actually a rumor that circulated that was then fact-checked and found, it was found that there wasn't a connection between the vaccine and these deaths. And importantly, this tweet isn't outright saying that the vaccine is unsafe. It's working on an implication that was really common in the data set. So having to kind of read between the lines. And then the last two we would code as neutral. So this one is arguing against vaccine mandates, but what we would say is that this is an argument about the policy itself, because they're saying it's a violation of civil liberties. They're not actually saying anything about whether the vaccine is safe and effective. So we're specifically looking at arguments about the vaccine itself. And then the last one we would also code as neutral because it's providing information without a stance. So from there, we have this sample of popular users. It looks like this got a little bit messed up in the cropping. So pretend that you don't see this fourth bar at the end here. Myself and both of the research assistants would go through and label all of these tweets. We had about 400 of them. So 10 for each of these highly central users. And you can see here, pink is negative, white is neutral, and green is positive. And there would be disagreements between us, like you can already see them here. But importantly, we found that if you look at like whether we thought that a given user was saying more negative or positive things, we generally really strongly agreed on this. So here, all of us agreed that this person was making more negative arguments. And just to give you a sense then of what our full results would look like, this top row is 20 users from that anti-community, and the bottom is 20 from the pro community. So generally, you're seeing more pink in the top row, more green in the bottom row, but there were exceptions. I'm happy to talk about those more. But so that's how we determined the community stances. And I'm happy to talk more about that, but let me get a little bit more into this. Have you looked beyond perception of expertise to trust? How might looking at trust change your results? That is a great question. So one thing that I'll say is, we have a follow-up study that we're hoping to preprint in the next couple of days, where we actually had people look at fake profiles with these, with and without these, what we called expertise cues, and actually ask people like, do you think that this person is an expert? And we did find this really significant effect where the people who have academic and professional credentials associated with biomedical sciences are seen to be experts. And further, and this goes back to the first question, that effect holds regardless of vaccination status, vaccine hesitancy, and political affiliation. So people with these credentials are seen as experts across these different groups. However, trust is a really different question. And I think that's a really good point. It probably is moderating the effects that we see here. I think really what we're finding is probably an interaction between content bias and motivated reasoning, where you're more likely to listen to and engage with people in your who align with your stance, and a preference for experts. So kind of prestige bias, people who have these cues of these credentials in their profiles. So I think that that is probably where you would start to see two differences based on things like partisanship, vaccine status, vaccine hesitancy. This is also another limitation of, for example, this sort of binary classification into pro and anti-vaccine communities, that there's probably some heterogeneity in why people are coming to these attitudes and like what their specific qualms are. So I definitely think that looking at trust could change the results, and that's an important thing to follow up on. Then the next question is about refuting anti or pro-vaccine messaging. So that is a really good question too, because, for example, you could share a low quality source in the hopes of fact checking it. And I think it doesn't seem like that's happening very much, because we still had just really low rates of sharing of low quality links in the pro-vaccine community. But I will say we had an additional analysis where we looked at bridging accounts. So these accounts that show up, sorry, I'm flashing through these, right between the two communities. And even though, for example, this perceived expert gets put into the anti-vaccine community, when we actually looked at what this person was tweeting, it was a lot of fact checking. So I think it's more kind of on the margins, like you actually can see it in the network, that people who show up between the communities are potentially engaged in this fact checking behavior. That's a pretty small subset of users. Like we didn't really see much fact checking in these highly central nodes, although we did see some, especially from the pro-vaccine community. But yeah, I'll just say that of the 10 top bridges between the two communities, 5 of them, 50% were perceived experts. So they're massively overrepresented there, and almost all of them are engaging in fact checking. Software did you use to analyze the data from Twitter? So we conducted all of these analyses in R. The network plots are from Gephi. I think I'm pronouncing that right. And then the Twitter data is from the University of Washington Center for an Informed Public. So they had this sort of academic access where they could build these collections. Obviously, there is now, limitation of access to that sort of data under Twitter's new management, but this is prior to when that happened. Did you consider emoji usage in tweets? And then there's also a question about large language models. I think both of these are kind of similar in terms of looking at content. So we did not do any large language models. I think there's definitely room for follow-up around that. I think a really cool study could be looking at what sort of languages perceived experts use versus perceived non-experts, and whether there are sort of linguistic differences. But for right now, this is a first pass at a problem that's really understudied, specifically these perceived experts and the roles that they play. So we did not use those. But again, I think that's something that I'm really interested in for next steps. I think for all of this stuff on decision-making and behavior. Emoji usage, so we would see emojis. We don't have any specific analysis around them. That is something, again, that I think if you were looking more specifically on content, you could compare things like how are perceived experts versus perceived non-experts using them. There's also been some work on ways that the anti-vaccine community evades content moderation through the use of emojis. We didn't encounter that very much here, although part of that might be that we wouldn't be picking up those tweets necessarily if they're not using vaccine related keywords because they're using those emojis. And then Stephen, hi Stephen, thank you for coming. Have a good sense for what the different community modules that pop out represent. Yes, so let me show you, actually, that is a great question, because what we can do with InfoMap is it's hierarchical. It also shows us sub-communities within those big communities. And there's actually meaning to these sub-communities. So we can, again, just look at sort of a sample of popular tweets in each of the sub-communities. And what we find is the pro-vaccine community, you have sort of this one large chunk that's mainly US centric, but it's more just focused on vaccines in general. It's a lot of discussion about early clinical trial results. And then it splits in half from this media side. So you saw almost all of these users were excluded. These are a lot of, for example, I think newspapers. Then we also have these splinters of folks really focused on Canada and Australia, and they're really critiquing their government's policies around vaccine administration, criticizing the rollout for being too slow, kind of emblematic. I think someone compares the vaccine rollout in one of these countries to Fire Festival. So that's what those two are. And then in the anti-community, again, we have this splitting, but it seems like what's happening there is from other analyses based off of similar data sets in a political context. They found that there are these follow back clusters, which are engaged in this sort of highly coordinated, almost spammy behavior. And that's enough to, like, being linked to those follow back networks will kind of separate out part of this anti-vaccine community. So one of them is connected more to the follow backs, and then one of them is connected a bit more to the pro-vaccine community and sort of news that's coming out. And then we also have these language-based French and Italian communities that group with the anti-vaccine. The third largest community is focused on vaccination in India. And I wasn't able to find a difference between those two submodules, but it breaks into two groups. So that's what those are. And then the second question is about using Twitter / other social media in the future for this type of analysis. So I think there's a lot of potential there. I actually think there may be an opportunity now that we have less access to Twitter data to consider other potential sources, even though I know that other sources are also limiting access. But I'm particularly interested in places like Reddit and TikTok, which are honestly where a lot more people are getting information. It made sense to focus on Twitter for this study for several reasons, but I am hopeful that the recent changes in access to Twitter data can actually help us start thinking about new ways of incorporating other types of social media data. So I think I've run through the Q&A. Maybe I'll go back to my email if anyone comes up with a question that they weren't able to ask, but I think we're about at time. Cool. Thank you all so much for coming.
Yes, thank you, Mallory.
Thank you. Thanks for having me.
Oh, sure. Sorry. I also posted your email in the chat, although it separated it there.
Okay, great. Yes, would love to hear from everyone. All right. Thank you all so much. Have a great rest of your day.
Thank you so much.
Bye.
Bye, everyone.